ということでですね、その医療利用の部分に関しまして、今日ですね、フッキーって世界で一番詳しい方に来ていただいてますので、マイクを渡して、安藤先生お願いします。
I'm honored to be here. This is my email address. UG has offered to make these slides available as a PDF subsequent to the talk. There is a lot of material written on here. We will not be going over all of it, but just the highlights. But hopefully you will have time to study it later, and I would be happy to hear from you with your questions subsequently. As you've heard, we're discussing cannabis sativa. That means cultivated cannabis, and the medicinal part of the unfertilized female flowering tops that concentrate cannabinoids and also terpenoids, the aromatic compounds that are produced in these areas called glandular trichomes. The most famous, of course, is tetrahydrocannabinol, or THC. It binds to a receptor called cannabinoid 1, CB1, as do these compounds, endogenous or endocannabinoids, the best known being anandamide and 2-arachidonylglycerol, or 2-AG. Anandamide and THC are both weak, partial agonists at this receptor. There are synthetic cannabinoids that are sold on the black market that are full agonists and more than 100 times more potent. So those compounds have little in common with how the natural compounds act. There are actually three types of cannabinoids: the phyto or plant-based cannabinoids like THC and cannabidiol, CBD, but also the endocannabinoids that I've just mentioned. The endocannabinoid system that we'll discuss more has many functions. They've been summarized as relax, eat, sleep, forget, and protect. There are also synthetic molecules that may or may not resemble the molecular structure but affect the system as well. How the cannabinoids work in the nervous system is quite complex. The endocannabinoids are not neurotransmitters that would go in an anterograde fashion from the presynaptic neuron to the postsynaptic neuron. Rather, 2-AG in particular is produced on demand in the postsynaptic neuron. It travels in a retrograde fashion to lodge on CB1, where it inhibits the release of neurotransmitters. In this depiction, this is glutamate, the stimulatory neurotransmitter. When this is present in excess, it will drive neuropathic pain or even excitotoxicity after head injury or stroke. CB1 is expressed in various areas of the brain, particularly higher centers, nociceptive areas related to pain, also in the cerebellum, the basal ganglia, and in reward pathways. They're in certain areas of the brainstem, but not in cardiorespiratory centers, so there is no dose of a cannabinoid that will produce respiratory arrest. So this is quite distinct from the problem with opioids, where there's significant mortality related to overdoses. But they're also elsewhere in the body. Beyond the brain, they're in the spinal cord, they're in the enteric nervous system, where they modulate both propulsion and secretion, and out in the periphery. I should mention that the CB1 receptor serving this modulatory function is the most common G protein coupled receptor in the brain. Its density exceeds the total for all of the receptors for all of the neurotransmitters in the brain. There is also an additional receptor called CB2. This is a non-psychoactive receptor mainly in the periphery, but expressed in the brain under conditions of insult or inflammation. Out in the body, this is an immunomodulatory receptor that's also involved in inflammation and analgesia. It also has an anti-fibrotic effect, so it could be used to treat hepatic or cardiac fibrosis. Additionally, it's in other organs, and although it's not depicted here, it is in the heart and in the skeleton. Recently, cannabidiol, a compound from cannabis, was demonstrated to stimulate bone fracture healing. This is a plate from an upcoming chapter that will be out in August that shows the various parts of the plant, from the roots up to the flowering tops. Now we're going to be mainly concentrating today on the drugs from this portion. But for example, there are alkaloids and triterpenoids in the roots that have medicinal uses as well. Every part of the plant has some particular biochemical compound that it makes that may be therapeutic. Now we won't spend a lot of time on chemistry, but these are some of the phytocannabinoids. As you see, it's not just THC and CBD. There have been over 100 of these compounds described, specifically in cannabis, although some are artifacts of isolation. This is the biosynthetic pathway. We start with two precursors, olivotolic acid and geranyl-pyrophosphate, that then produce the cannabinoids, which in the plant are in carboxylic acid form. Normally, these are decarboxylated by heat, either by smoking or baking, to produce the more active neutral cannabinoids. This compound, geranyl-pyrophosphate, is also a parent compound to the terpenoids that we will be discussing. Some detail on THC. This was only identified in 1964. This is an analgesic compound. It's also a bronchodilator. In the 19th century, there were cannabis cigarettes used to treat asthma. It also is a neuroprotective antioxidant. There actually is a patent in the USA on this compound for that purpose, even though it's still considered a Schedule I forbidden compound. It is a very powerful muscle relaxant, as we'll discuss, and it's unique as compared to the commercial drugs that are muscle relaxants in that it does not produce weakness. This is an approved indication for the drug called Sativex in 29 countries in treatment of MS spasticity. It is an antiemetic, well known for its ability to combat nausea and vomiting in chemotherapy. It is the primary psychoactive component. It's not a COX-1 or COX-2 inhibitor, and it's been shown to reduce beta amyloid formation, of particular interest in Alzheimer's disease, but also in amyloidosis. So this is a very promising compound. In addition to that effect, it's a very good drug for neuropathic pain, as we will see subsequently. Less familiar, perhaps, but now getting more attention is cannabidiol. This actually does not bind to the orthosteric site on CB1 or CB2, but when present even in low concentrations, it will counteract many of the deleterious effects of THC, such as rapid heart rate or the production of anxiety. It was recently shown that this is a negative allosteric modulator. It's affecting a different site and changing the conformation of the receptor. It is, again, a strong neuroprotective antioxidant, more powerful than tocopherol or ascorbate. It also is a TRPV1 agonist like capsaicin and can desensitize that receptor in neuropathic pain. It also has the ability to upregulate the endocannabinoid system by increasing the availability of anandamide, the endocannabinoid. It is a very broad-spectrum anticonvulsant. Medicine called Epidiolex. It has completed successful phase 3 clinical trials and should be approved by the Food and Drug Administration of the United States for treatment of Dravet and Lennox-Gastaut syndrome. It is an anti-anxiety agent. It shares with the other cannabinoids a unique property of being cytotoxic for cancer cells, but producing no toxicity for normal cells. This is in high doses, so this makes it a good candidate as an adjunct in chemotherapy. It also antagonizes tumor necrosis factor alpha and rheumatoid arthritis, but should be equally applicable to inflammatory bowel diseases and some other autoimmune conditions. Again, it's not a COX-1 or COX-2 inhibitor. It is an agonist at the serotonin 1A receptor. This is an effect that I showed with my colleagues at the University of Montana, and this explains its effects as an anti-anxiety agent, but also as an antiemetic. Another interesting one is that it can prevent slow virus prion accumulation. There are many misconceptions about this. This is a very interesting compound that has many effects, but it's not very potent. Generally, a high dose is needed to be effective. You will hear people say that it's not psychoactive, but it clearly is because it's anti-anxiety and antipsychotic. Some people will say it is sedating. It really is not. However, types of cannabis that have a good amount of cannabidiol also tend to have very high amounts of myrcene, another compound that is sedating that we'll discuss. Some people will claim this is legal. In the United States, it's not. It's illegal throughout the United States and is a Schedule I compound. Last year, there were reports that when CBD was exposed to strong stomach acid for an hour, it could be converted to THC. This reaction was actually known in 1940. However, this does not occur in the human body at all. Even high doses will not produce any serum level of THC when it is a pure compound. This is from a recent article, and it just shows going from the plant down to pure CBD, which looks like this, and again to emphasize that it goes through hepatic metabolism and is not turned into THC. Additionally, in cannabis, I've mentioned that it produces aromatic compounds called the terpenoids. And these will be familiar to you in their role in other plants, such as limonene from lemons, pinene from pine needles, etc. These are present in smaller concentrations in cannabis, but despite that lower concentration, they're very powerful pharmacologically and will synergize with the cannabinoids in the production of various effects, which include pain reduction, reduction of inflammation, and benefits on mood, anxiety, depression, etc. These are some of the monoterpenoids, the 10 carbon compounds. You'll note that they have carbon and hydrogen. Some have oxygen, but no nitrogen. One of these is pinene. Pinene comes from pine needles. We know that this has a tendency to clear the head. You have a term for this in your language, Shinrin Yoku, or forest bathing. One way that this will clear the head is if you walk in a pine forest, this will be in the air. To explain that, I can point out that this is an acetylcholinesterase inhibitor. One of the notorious side effects of THC is the production of short-term memory impairment, but that can be totally reversed if this is present in the cannabis. Unfortunately, in commercial varieties of cannabis, chemovars, chemical varieties, this is not usually present to any degree. But it has other effects that are interesting. It's strongly anti-inflammatory through prostaglandin E1, and it is a wide-spectrum antibiotic, particularly against gram-negative organisms. More common in cannabis is this terpenoid called myrcene. Myrcene is present in celery leaves. It also is anti-inflammatory and analgesic. Interestingly, that analgesic effect will be reversed by naloxone, the mu-opioid antagonist. It is quite sedating when combined with THC, producing an effect that's called in slang American terms couch lock. That means when this is present, the person is immobilized, can't move. I suppose that some people like this, but there tends to be too much myrcene in American chemovars. This is not good for a patient who has to treat their pain, for example, and work and study at the same time. Another terpenoid in cannabis is limonene. This will be familiar as lemon scent for many of the citrus varieties, but it also is a potent antidepressant and immune stimulator. In the 1990s, a group in Japan, Komori et al., wafted this into the air in a psychiatric ward with depressed patients and cut their Hamilton depression scores in half and allowed them to discontinue their standard antidepressant treatment. It is widely bioavailable. Another recent effect that was noted is it will increase mitochondrial biogenesis and turn white fat into brown fat, may have a future role in treating obesity. Another one in cannabis is linalool. It's also present in lavender, as we see here. It is a strong anti-anxiety agent, local anesthetic for the skin. It can help prevent burns. It also is strongly anticonvulsant, and when it is present in cannabis, performs an adjunctive role with other anticonvulsant compounds in cannabis, as we'll see. There are also 15 carbon sesquiterpenoids in cannabis, especially this one, beta-caryophyllene, that's present in black pepper. This is anti-inflammatory through prostaglandin E1, but unlike non-steroidal anti-inflammatories, it is a gastric cytoprotective. It helps prevent ulcers. 10 years ago, it was noted that this is a very selective CB2 full agonist and very specific. And it has no CB1 activity, so this would not produce intoxication, but rather could exert anti-inflammatory and analgesic effects through the CB2 receptor. That is particularly of interest in such agents have an antifibrotic effect in the liver and also should have application in treating addiction to compounds like cocaine or the opioids. There is a lot of confusion about how to call cannabis, how many species there are, for example. You'll hear the terms sativa and indica referred to, but these really are not helpful in describing the effects of the plant. Rather, we need to know its chemical content to know what effects it's likely to have pharmacologically. This is one scheme for depicting that. We see up at the top, it shows the percentage of cannabinoids and terpenoids. They're the proportion of the cannabinoids, a picture of the source plant, what the aromatic compounds are, and their taste or smell as the consumer describes them, and then their effects. Down here we have bars of concentrations of the terpenoids. This one is rich in limonene, which should make it a good antidepressant, but additionally in caryophyllene, so good for pain and inflammation, particularly in conjunction with the high amount of THC. What it has very little of is myrcene, and so this will not be a sedating type of cannabis. Now let's talk a little bit about the effects of cannabinoids on pain. The endocannabinoid system works at a tonic level in control of pain, and it is densely packed in the nociceptive areas of the brain. For example, in the periaqueductal gray that generates migraine, but also in the ventroposterolateral nucleus of the thalamus, where cannabinoids are 10 times more potent than in wide dynamic range neurons than the opioids. It also is quite active in the spinal cord, where such phenomena as allodynia and wind-up are noted in neuropathic pain states. This is a table of randomized controlled trials of a specific preparation called Sativex or nabiximols in pain. This is the same medicine that is approved in 29 countries for treatment of spasticity and MS. As you all note here, almost all of these trials have had positive results, including peripheral neuropathic pain. There may, in the early studies, have been amyloidosis patients. I strongly suspect it would be helpful there as well. But if we look at smoked or vaporized cannabis studies, randomized controlled trials in pain that were mainly done in the United States, it's only 3 patient years of data. These were small numbers of patients for very limited durations of time. Just the published studies in nabiximols total 6,000 patient years. So there is extensive documented experience with this agent. Now we're going to shift a discussion of MS. This is an old study from 1981 showing the effects of THC over time on spasticity. Here is placebo, and then 5 and 10 milligrams of THC. And as you see, there's a peak of activity at 3 hours and trailing off after about 6 hours. And that's with THC alone. This is a description of Sativex or nabiximols. This is made from 2 chemovars of cannabis, one rich in THC, one rich in CBD, but also some terpenoid content in a vehicle of ethanol and propylene glycol with a masking agent of peppermint. This is sprayed in the oral mucosa so that it has an intermediate onset, much slower than inhalation, which will tend to increase psychoactivity, and a little bit faster than purely GI absorption. This is accepted as a unitary formulation, and each spray, 100 microliters, provides 2.7 milligrams of THC and 2.5 milligrams of CBD, and so it's very easy to titrate. One may wonder how you make a prescription product, pharmaceutical, out of a natural product from a plant, but it can be done. It needs a high level of standardization as well as consistency, but that is demonstrated here. This is 25 batches of nabiximols over 9 years, and the different cannabinoids, but I think you'll agree that the superimposed traces look like single peaks, showing how consistent it really is. This is a table of the multiple sclerosis clinical trials, and again, if you look carefully at the p-values, you'll see that most of these were positive and led to the approval. The pivotal trial was done in an interesting way. There had been a couple of negative clinical trials because of overly prominent placebo responses. So that even though Sativex seemed to help, so did placebo, and it wasn't statistically significant in all cases. So they used a novel design called a randomized withdrawal trial. And this was in over 600 patients. Initially, unbeknownst to them, all the patients received Sativex. After a month, only the responders with a significant improvement in spasticity were then randomized to receive the same number of Sativex sprays a day or the same number of sprays of placebo. After that time, there was a marked divergence of effect, and this was highly statistically significant. There was a mean 48% improvement in spasticity on nabiximols over the course of 4 months. On the right, we have a detailed explanation of the effects of cannabinoids on muscle tone. Basically, agonism at CB1 reduces muscle tone, whereas antagonists like rimonabant, SR141716A, will increase muscle tone. And this acts on centers in the cortex, cerebellum, and spinal cord, especially the interneurons there. This is some more recent data that was taken post-marketing observations. This was a long-term open-label trial, 146 adults with MS for about a year. And what was seen was that the spasticity scores slowly continued to decrease over time. There was no tolerance that developed to the medicine that required dose escalation, and there were no major psychiatric adverse events. When people stopped the medicine, even abruptly, no withdrawal effects were noted. And you might be concerned about intoxication with such a medicine that contains THC, but the visual analog scales of intoxication were very low to begin with, 5.45 on a 100-point scale, but that went down over time. So there was a tolerance to the low level of intoxicating effects to begin with. And there were no episodes of hallucination or major psychiatric problems. Another study, this was another randomized withdrawal study in a lower number of patients. And when they suddenly stopped the medicine, 94% of the placebo patients failed. Their spasticity got worse, versus only 44% of the nabiximol patients. But the study was so well blinded that some of the people who were on nabiximols thought that they were worse when they in fact weren't. Again, there were no withdrawal symptoms. This came out of Germany, so it's a real-world evaluation of 276 patients. After a month, almost 75% were improved with numerical rating scales 0 to 10, decreasing from 6.1, which would be moderately severe spasticity, down to 5.2. After 3 months, well over half continued the drug, with another 25% decrease in the numerical rating scale of spasticity. Actually, over a quarter of the patients were on no other drugs for spasticity. Normally, this had been added to an existing optimized treatment course, in other words, as an adjunct, but this proved to be a very good standalone drug. And there were improvements in the Ashworth scale, which I don't believe in anyway, but it was better. Just a graphic depiction here. You see the equinovarus on this patient's ankle before treatment, but after treatment with nabiximols, it's quite straight. More data from Germany. 150 patients in the clinical trials and then 900 post-marketing. What they found post-marketing was the doses required actually were a little bit less than they'd used in the clinical trials. Somewhere between 5 and 6.4 sprays a day, which is not a very high dose. They had very dramatic improvements from spasticity score of 6 down to 3.6, which was very statistically significant. One patient had suicidal ideation, but they were on placebo. And there was no evidence of cognitive decline, depression, or mood changes. And there was good adherence. At 6 months, 69% continued the medicine. And you would not likely see that with conventional agents like baclofen or tizanidine, I would wager. There's also concern about effects on driving, but this was done in MS patients before and after treatment with nabiximols. None of these here are significantly different. However, there was actually improvement with treatment on the scale called determination. So you understand that if someone is quite spastic and it's hard to move, and their muscle tone is then decreased on treatment, it may make it easier for them to drive appropriately. Another concern, of course, is will this medicine produce an impairment in cognition, which already may be challenged in multiple sclerosis? Here we see that that is not the case. No difference between placebo before and after, and at the same time there was clear improvement in functional status as judged by the global impressions of change by the patients, the physicians, and the caregivers. And there was good statistical significance to those as well. In terms of side effects, vertigo and dizziness were the most prominent, but were still under 10% for each of these. In the past, when higher doses were used and the titration was done more rapidly, those numbers would be quite a bit higher. But what we've learned is that this medication works very well at low doses, and that is the best approach. And again, more about side effects, but I want to draw attention to the bottom. Physicians rated 84% of patients as gaining worthwhile benefits from this preparation. This is from the Spanish patients, and there were a very low number, 2.4%, that had any kind of psychiatric side effect, and none had suicidal ideation. This is just a flow chart, and these experts evaluated that patients who did not respond to a single trial of baclofen or tizanidine should be considered for nabiximols treatment. And then if that wasn't optimal, it could be combined again. This is in comparison to a study of smoked cannabis acutely for spasticity in MS, but it was only a 3-day trial, and although there was improvement, it's not long enough to represent an advance in getting an approval for such an agent. Additionally, there were serious problems in that the paced auditory serial addition test decreased to a highly significant degree. Also, there was not suitable blinding. The patients who were smoking the cannabis rated themselves as high, again with high statistical significance. So they could tell what they were taking. So this really pretty much invalidates the study according to modern techniques. The Food and Drug Administration will never approve a smoked medication. Now, a little bit about lower urinary tract symptoms. This is an older study again, bladder dysfunction in MS, and as we see at the bottom, there were a decreased number of incontinence episodes, waking at night to avoid fewer frequency episodes during the day. Another study, this is a phase 2 level for 8 weeks, and they were looking at a variety of measures that we'll see here. Now, unfortunately, there was an error made in that this study was not powered properly. These patients were severely affected. They had an average of 1 incontinence episode a day, and as you see here, in the study, there was no difference between Sativex and placebo. However, in terms of bladder symptom severity, there was a significant preference for Sativex. Also in frequency per 24 hours, episodes of nocturia, nighttime problems, urgency, patient global impression of change. Unfortunately, there's been no follow-up on this, although patients continue to use it with success. And this is just a depiction of nocturia episodes. How about tremor? This is with MS. Now, there have actually been studies of this. This is just one patient, and you see before and after, in this instance, smoking a joint, and how much better the drawing is. And another depiction. Unfortunately, when this has been studied, we find that occasionally this works, but not to a significant degree, and so it's a very hit or miss type of proposition. Now, we're going to transition to a discussion of epilepsy. In 2003, it was shown that seizure threshold is mediated by endocannabinoid mechanisms. Interestingly, THC was able to reduce 100% of seizures in test animals where phenobarbital and diphenylhydantoin did not. Interestingly, when an antagonist was applied, the seizures got worse. And also interesting was the anticonvulsant effects of THC were present at a dose that was not sedating. And the same is true in humans. Subsequently, there was this survey done looking at families that were utilizing cannabidiol preparations to treat their children with severe seizure disorders, and this included Dravet syndrome, DOSA, and Lennox-Gastaut. But the patients were very severe. They had an average of 12 anticonvulsant drugs previously. In this small cohort, 84% of the families reported decrease in seizures on cannabidiol. 11% were seizure-free, 42% had an 80% reduction, and 32% had between 25 and 60% reduction. There were side effects, drowsiness and fatigue, but they also reported some side benefits of improved mood, increased alertness, and better sleep. However, this was just a survey with no control group. A study from Colorado where cannabis has been legal looked at 75 patients who were recommended cannabis for seizures, and 57% reported improvement, with 33% a greater than 50% reduction. However, there was something very odd. The response rate for families that moved to Colorado for treatment was 47%, but only 22% for those who were born in Colorado. Obviously, there was a placebo effect in the parents in the study. So these results must be looked at with great skepticism. In comparison, an observational study was done with a preparation Epidiolex, which is a high CBD extract with no THC, and they got very good results. Subsequently, a couple of weeks ago, the same author has an article in the New England Journal of Medicine with results that are quite comparable and in a controlled study. Now, they were using high doses. The mean dose was about 23 milligrams per kilogram per day, which is a lot of medicine and would be quite expensive. There were limited side effects. The sedation was common when the children were also on clobazam, because CBD will cause an increase in N-desmethylclobazam metabolite, which is sedating, but this responded to reducing the dose of clobazam. There was a 35% decrease in total seizures. Again, 39% of the children had a greater than 50% reduction, 21% and greater than 70% reduction, and 9% greater than 90% reduction. And it was effective in both Dravet and Lennox-Gastaut syndromes. The clinical trial results are essentially equivalent, again, in controlled studies. I just didn't have time to make a slide from that. Now, interesting fact. We've known for a long time that this substance, cannabidiol, could be good for seizures because it was described in 1979. And it was noted that the existing drugs at that time did not always work and could have a lot of toxicity of their own. And it was recommended that CBD be tried for epilepsy. It unfortunately took another 30 plus years for this work to begin in earnest. Just a few comments on traumatic brain injury. As you're aware, this is poorly treated by any conventional drug. As I've mentioned, both THC and CBD are neuroprotective antioxidants. Particularly the anti-glutamatergic effect of CBD may prevent glutamate excitotoxicity that leads to neuronal demise after traumatic brain injury and chronic traumatic encephalopathy. I can tell you that anecdotally, chemovars that have THC and CBD have been extremely helpful in these kinds of symptoms, including headache, nausea, insomnia, dizziness, agitation, substance abuse, and psychotic symptoms. So this is something that really deserves a good clinical trial. You may recognize one of the fathers of neurology, Sir William Gowers. He described a case of what seemed to be Parkinsonism, noted that after prolonged treatment with Indian hemp, which was cannabis, that after a year the tremordomas ceased. Subsequently, in the Czech Republic, in the last decade, a bunch of people were trying cannabis in Parkinsonism. But an interesting phenomenon was noted that mirrors what Gowers noted. There seemed to be a delay in improvement. People had to take it for a couple of months. Now, this is really different than other indications where cannabis often produces an effect immediately that may improve with continued administration. There's something different in Parkinson's disease. Something is going on there, so it takes longer. But for the patients who took it for 3 months or more, general symptoms improved, highly statistically significant. There was improvement in tremor, bradykinesia, and rigidity. And only very few patients discontinued because of side effects, and they were taking it orally. Another study from Brazil in 21 patients just using CBD and oil, and they saw improvement in Parkinson's disease questionnaire, also activities of daily living. A little bit about amyotrophic lateral sclerosis. Again, we have limited success in life extension with available drugs such as riluzole. In animal studies, THC prevented excitotoxicity in the anterior horn cells. It increased exercise endurance in the mouse model of this disease, and survival was increased significantly. So there was also a suggestion that CBD would be neuroprotective. On the clinical side, Greg Carter is a colleague of mine in the state of Washington, and he wrote an article talking about the pharmacological benefits in treating ALS, and he's done this with a lot of patients. We've mentioned the glutamate antagonism, the anti-inflammatory effects, modulation of microglia via tumor necrosis factor alpha, preventing apoptosis in the cells that are affected, nerve growth factor stimulation, and enhancement of mitochondrial function. But beyond that, symptomatically, this offers a great deal. Pain relief, muscle relaxant for the subset that have spasticity, bronchodilation, decrease in saliva production, stimulation of appetite, and improvement in sleep. Another of my colleagues, Kirsten Muller-Wahl, in Germany, has done extensive work using THC and cannabis in Tourette syndrome. In this study, she used THC in 24 subjects, up to 10 milligrams a day, over 6 weeks in a randomized controlled trial, with improvement in Tourette's symptoms that was statistically significant. In conclusion, the endocannabinoid system has an important role in mediation of spasticity and seizure threshold as well as many other neurological effects. It's important that you understand that this is very dependent on the preparation. So you cannot necessarily extrapolate the results of one preparation to another unless you know what the components are. Additionally, cannabidiol has strong evidence of safety and efficacy in epilepsy, but cannabis-based preparations additionally show promise in amyotrophic lateral sclerosis, Parkinson's disease, and Tourette's syndrome. Thank you for your attention.
10 minutes is left. If you have any question or suggestion or comments, would you please give us? Or you? It's or you.
Thank you very much for your educational and exciting presentation. So I have a couple of questions about your presentation. So I have until now, so I haven't heard such a multiple function of cannabinoids. So as you said, cannabinoid, and you said that cannabidol has neuroprotective anti-glutamate toxicity as well as antioxidation. So this function is what I want to ask you is such function is whether it depends on the CB1 receptor or not.
Yes, it seems to be mediated through the CB1 receptor. So when there's stimulation there, either directly by THC or indirectly from cannabidiol by increasing anandamide or via other effects, there's a reduction in the secretion of glutamate and thus, in some instances, less excitotoxicity and at least in animals, less cell death. There have been demonstrations of smaller volume of stroke after carotid ligation and smaller areas of damage after traumatic injury in rodents. There's been extensive work, much of it in Israel, in this area.
So if such functionings depend on the CB1 receptor pathway, so the benefit should be observed in where the receptor exists. I mean, you show that CB1 is present in the cerebellum.
Right. Yeah, it'd be in all the pertinent areas. Additionally, with cannabidiol, again, let me emphasize, this is a non-intoxicating agent. So, but THC will work in a dose that does not produce impairment itself. I can tell you that in my practice of neurology, I had patients who, with my direction, would use cannabis after post-concussion syndrome, and they reported clearer thinking, and it was evident in their ability to work earlier. I saw a great deal of traumatic head injury in Montana, cowboys, and it's a rough place. There were a lot of head injuries from one thing or another, but I saw great benefit to this where other drugs did not work.
Is the distribution of CB1 and CB2 different?
Yes. CB1 is throughout the body, but very concentrated in higher centers. CB2 is mainly peripheral. It will only be expressed in the brain under conditions of injury or inflammation. So it is upregulated in MS after head injury or stroke, yes.
Another question is, I thought that oral mucosa spray is very reasonable for your clinical use. So I can understand that the speed of intake of
nabiximols, right?
It depends on the way of the intake. So in my mind, the spray is seem more quick, and smoking is more slow.
No, much faster.
Much faster.
Yeah, basically on inhalation, the effect is about the same as it would be with intravenous administration. With strong cannabis, the effects will be felt before the person finishes exhaling. It's extremely rapid. Now, this is good if you wish to be intoxicated. It is bad if you wish to reduce side effects because the serum level and brain level spike. With Sativex, and I didn't show this, you have very slow absorption, and of course it's going to go preferentially to the brain because of the lipophilicity of the molecules.
So my concern is the speed of the intake has some kind of relationship with the central effect on the central nervous system.
Absolutely. Right. And because of drug abuse liability, slower is better. Also, I want to emphasize, we're dealing with chronic diseases. I like to tell the patient, we want you to get better, but we want you to get better slowly. In other words, to gradually bring the medicine up so that we find out the dose that controls your symptoms without producing any of these side effects that people are so concerned about. But that can be done. As compared to THC alone, cannabis, because of these other compounds we discussed, has a wider therapeutic index. The margin of safety between the dose that affects symptoms versus that produces side effects is much wider.
Okay. Thank you very much.
Is that okay with you? Any other question or comments? Dr. Nakane?
Thank you very much for your nice lecture. I'm very impressed, but I'm a little nervous because this is first time to listen the lecture regarding cannabis and others. My question, I have two questions. My first question is President Trump. What does he think about cannabis and some products from cannabis?
He knows nothing about this. He said before...
Against?
Well, yeah, I believe so. And he's appointed people who are dead against it, but also know nothing about this. Before the election, he thought it should be up to the states. Now, as you've seen from Yuji's talk, 29 states have some kind of medical access, and several have made it legal. The people want this. 90% of Americans feel that cannabis should be medically available. Now, that's not the way medicines are approved, but I think you would agree that we have abundant evidence of both efficacy and safety for these medicines. That doesn't mean that you shouldn't worry. It doesn't mean that everyone should do it. It doesn't mean that it's fine for teenagers to smoke cannabis every day instead of studying or playing sports. None of those things. What it means is patients who are seriously ill would benefit from this if it's properly used. That's what I'm saying.
I like your question very much.
Thank you very much. Can I go to the next question?
Sure. Just short.
Okay.
We are running short of time.
Yes, okay. Second question is immunology. And you told us CBD is effective for rheumatoid arthritis, cancer, and multiple sclerosis. How can CBD control immune system? For example, CBD2 receptor is expressed in the organs related to the immune system or lymphocytes or macrophage.
Right. Well, it is immunomodulatory. It's not immunosuppressant. THC will be immunosuppressant, but at doses that are 50 to 100 times the psychoactive dose. So there is that effect, but it's not pertinent to how this is actually used. The immune effects of cannabidiol would be mediated through mainly through TNF-alpha and possibly other mechanisms. There are 30 main mechanisms of action of cannabidiol. Now, that sounds like a problem. It makes it a dirty drug, but dirty drugs are often ones that work, and none of those 30 mechanisms of action are deleterious.
Thank you.
Okay? Yes. My last question is very simple. What is the beneficial point, superior point to use the cannabinoid than other commercial drugs? Because cannabinoid is a symptomatic drug. We have many symptomatic drugs commercially. So what is the sales point to use a cannabinoid? That is a very simple, but that is a very important question.
Right. I can tell you that every trial of Sativex and Epidiolex were done in patients who were intractable, who had failed conventional treatment and remained on those drugs. So any benefit that you saw in these studies was over and above that which was achieved with the conventional drugs. So one answer to your question would be, you try it when other things fail. However, as we also saw from the German data, for spasticity, Sativex worked just fine as a standalone or first-line drug. My personal bias is that it often produces better results with fewer side effects than conventional drugs. But the question is also affected by politics. Right now, you don't have access to such medicines. But again, with additional knowledge and evidence of benefit and lack of harm, perhaps the situation can change here as well.
Okay. We learned a lot tonight, and we enjoyed your talk.
Arigato.
We will think about cannabinoid for future treatment for intractable disease of the neurological field. Thank you very much for your special talk.